Dopo un evento cardiaco acuto è meglio una rivascolarizzazione completa, che quindi prende in esame anche i vasi diversi rispetto a quello, al principale, diciamo così, colpevole, oppure alla rivascolarizzazione cosiddetta culprit. A questa domanda molto importante, vista appunto la numerosità di questi eventi, ha dato una risposta, pensiamo, definitiva allo studio complete, che è stato presentato in anteprima qui a Parigi al congresso dell'ESC, che noi ce lo siamo fatti spiegare dal primo autore dello studio, il professor Shamir Mehta. Professor Mehta, first of all, before going into the study, which is the main difference between the complete rivascolarization and the culprit rivascolarization, and which is the most used nowadays?
So all patients with a STEMI or a full-blown MI have PCI to their culprit lesion. That is the artery that caused the heart attack. But during the procedure, we often find additional blockages in the other arteries. These are the non-culprit arteries. And so a complete revascularization strategy is opening these non-culprit lesions, whereas a culprit-only strategy is leaving the non-culprit lesions for medical management and only treating the culprit.
So using the stent only in the culprit or in the different lesion that you find when you do the procedure?
That's correct, yes.
Which is the most used nowadays?
Well, it depends. I think doctors now do the best they can for their patients based on the knowledge that they have. We have not had prior studies that show that routine non-culprit lesion PCI reduces hard clinical outcomes like myocardial infarction. So we've had no evidence that it changes the disease course until now.
So which was the objective of the complete study and how you designed it?
So COMPLETE was a large randomized trial designed to determine if complete revascularization reduces hard outcomes such as death and MI compared with a culprit lesion only trial. It was a large global trial, 4,000 patients, 31 countries, 130 sites across the world. And Italy was one of the top enrolling countries in this trial.
The results seems very clear. Which are?
Yeah, the results are absolutely clear. There was a 26% relative risk reduction in the first co-primary endpoint of cardiovascular death or MI. The p-value was 0.004. And the second co-primary outcome was reduced by almost 50%, and the p-value there was less than 0.001.
So which is the main message of the study, and it will define in a different way the daily by daily practice?
So the main message from this trial is that routine non-culprit lesion PCI reduces hard outcomes, and it should be routinely considered for all patients with STEMI and multivessel disease.
It's a most costly procedure to do the complete instead of the culprit. So there will be pros and cons in the two approaches.
Yeah. So obviously, if there's an additional PCI procedure, that will add early costs. But the duration, the timing of when that procedure was performed was one day after the randomization. And patients are usually in hospital during that time anyway. So there will be an additional early cost, but there'll be a prevention of costs from recurrent hospitalization, from recurrent myocardial infarction, and unstable angina.
So it's worthwhile?
Well, it's worthwhile because it reduces major cardiovascular events. These are life-changing events for patients. This is what we do as physicians. We try to improve the prognosis in terms of these heart events.